Assalamu alaikum, everyone. First of all, I would like to thank you, Dr. Altaf, and the organizer of this conference to give me the opportunity to come and talk about this very important topic. I'm going to try to be quick in my presentation because I know you all are running behind schedule. So I just wanted to correct that I'm actually at Services Hospital, heading the department there, but I also am running an endovascular lab at new endovascular lab at Punjab Institute of Neurosciences. So I have a dual responsibility. So I have no conflict of interest. Starting forward, just to clarify the things, we are going to be talking primarily about the ischemic stroke today, but I'm going to just briefly touch base about the hemorrhagic one. So what is a stroke? So stroke is whenever there's going to be an interruption of a blood supply, either in the form of a clot coming in the blood vessel or the blood vessel rupturing, that is a stroke. The TIA is a transient ischemic attack where there is a flow problem, symptoms happen, and then the symptoms revert, and that's called a TIA, but there is no tissue damage. Whenever there's going to be a tissue damage, it's going to be called a stroke, even if the symptoms revert, because sometimes the small strokes can quickly heal. So this is a typical vessel that we see on a DSA in geography. And so if there's a clot, the whole vessel shuts down, so that's an ischemic stroke. And if it ruptures, so you can have different types of hemorrhages. You can have subarachnoid, you can have subdurals, you can have intraparenchymal hemorrhages, you can epidural hemorrhages. So there are different types of hemorrhages, but the only thing that will differentiate between a hemorrhage and ischemia is a plain CT brain. So you can see on the figure on this right side, there is a full-fledged wedge-shaped ischemic stroke where a blood vessel was occluded, and this is how the hypertensive bleeds will look like, a massive intracerebral hemorrhage with extension into the ventricles. So this is how you differentiate between an ischemic and a hemorrhagic stroke. Clinically, the only way you can probably guess maybe you're dealing with someone who has ischemic or hemorrhagic stroke is that if someone who has hemorrhagic event or is about to have one will be complaining of headaches. The blood pressure variations will be more dramatic. There can be sometimes association of a loss of consciousness or patient being a little bit drowsy. But in general, the CT will tell you whether you're dealing with ischemia or hemorrhage. In Pakistan, the numbers are slightly different. We fall in the developing countries as compared to the developed world, where the ratio is 80-20. Ours is probably 70-30, where 70% out of every 100 strokes, 70 will be ischemic, 30 will be hemorrhagic strokes. So any type of strokes require multidisciplinary approach. You need to have neurology, neurosurgery, rehab, all of this set up, because treating stroke is one aspect, figuring out why it happened and how to prevent it is the second, and then very frequently we come across situations where ischemic stroke patients require neurosurgical helps, or if the patient lands in a hospital where there's no neurosurgery backup or neurology backup and you have a hemorrhage, every delay that the patient has experienced, even with the hemorrhagic strokes, the outcomes are going to change. So it's a different topic, but it's not only the ischemic stroke, which is time dependent, the hemorrhagic strokes are also time dependent. So that's why they need to reach the appropriate centers in timely fashion. Why is it important? Because once the stroke starts evolving, for every minute the stroke is evolving, approximately 2 million neurons out of 25 to 28 billion neurons are going to start dying. So all the therapies are geared towards trying to reduce the number of neurons dying as compared to trying to reverse the whole thing. In brain, you cannot reverse anything because neuron is different than a myocardium cell, because the muscle can regenerate, brain cannot regenerate. So the neuron, once it dies, it dies. So the whole rush is about trying to save the number of neurons and try to early recanalize. So what are the treatment options? In Pakistan and developing countries, we have TPA, but in the Western countries, the TPA has been now being changed by tenecteplase. Tenecteplase has shown or is showing good results compared to TPA, even for the large vessel occlusions. The time window is, in general, anyone who's 80 and below, up to 4.5 hours from the time the clock starts. The clock starts when the symptoms start. Anyone who is in up to 8 hours window, plus minus 16 hours, I'm not going to go into the details because this whole thing, which patient is going to fall into which domain, whether just a TPA or endovascular or a combination or just endovascular, it's all hospital dependent. The first thing is that the patient has to arrive to the hospital to get the treatment started. But in general, the endovascular is up to 8 hours, but it can go up to 24 hours based on the recent literature. And there are different ways you can treat them. You can give intra-arterial drugs. We have stent retrievers. You can pull the clot out, or you can aspirate the clot out. And sometimes you have to mix the devices. For all of you in this room, you need to remember this thing, which is called as a stroke chain of survival. Please keep in mind that the strokes can only take place at 2 different places. One, either in the hospital. The second is outside the hospital. The outside the hospital can be inside your clinic. It can be in-house. It can be in the office. It can be on the road, anywhere. So these are the only 2 places where the strokes will take place. So the more emphasis has to be in these areas, because early recognition, dispatching the patient, use of the appropriate ambulance service in the city, and then the last 2 aspects are the part of the hospital. Primarily, the hospital is just number 4. But if you can see, the first 3 are the most important. So educating the physicians is as important as educating the public at large how to recognize a stroke.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I said,
Honey?
Oh, Dad!
Tim!
I need an ambulance to 7th floor
Tim!
rescue.
Tim, look at me,
I don't know
Gracie.
what the
Tell them to hurry. Tim, look at me. Look at me, Tim.
Mom, what do I tell
I don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going
Dad?
on, baby? My husband. He's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. I'm right here. Gracie, meet us there. Right here. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Huh? Just breathe. Tim? Tim?
Dad? Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
So this actually is a very powerful video, and you can see these are the videos that are shown in the Western world. We have now Urdu versions also. You can find them online, and you'll see more and more coming in probably this year. And it tells you how, when the crisis hits the patient, even the educated ones, the mother was able to identify the stroke signs, but the daughter was unable to do it because the anxiety, the panic, the fear factor. And this is the typical story that happens with any tragedy. That even if you are the best of the best, even if you're a doctor, you will probably not comprehend that my loved one could have a heart attack or a stroke. So that's a normal reaction, a human reaction. So, but calling the ambulance, going to the hospital, recognizing stroke signs, that's the first thing that needs to take place. Once the patient lands in the ER, that's where all the doctors have to play a major role in a teamwork. So this is the golden hour principle that we do at Services Hospital, which we started in 2021, and now it has grown quite a bit. So the patient, the transport, now the video, from the video I'm going to move forward. Let's say the transport, the patient is brought to the emergency room. Now everyone in the emergency room has their own role to play, and it has to be synchronized. So starting with the ER, they have to assess the patient within 10 minutes, order the labs, do the ECG, stabilize, weigh the patient, because TPA and the tenecteplase are weight-based drugs. So this all has to be done in 10 minutes. The first and the most important thing is you need to find out the last known well time. If the patient slept at 9 p.m. and came to you at 6 a.m. in the morning, the last known well time was 9 p.m. It was not 6 a.m. So something in between might have happened. Imaging can help you, because I told you in the beginning, it can go up to 24 hours for treatment. Obviously, the TPA window has gone if it's beyond 4.5 hours, but you need to figure out the last known well time. every hospital like ours also has a code fast number, services hospital. We don't share it with the public at large. Only select few in the administration know about it, but the ER medicine department knows the numbers. Whoever is on call and everything, they know the number. Now in the services hospital, we have a dedicated stroke bay as of last few months. So the patients come there, and that's how the stroke team gets activated, and the neurology steps in and they give the drugs. Within 15 minutes, the neurologist has to be called in. They have to do their assessment. They have to go over the inclusion-exclusion criteria, which is relatively a long list, but now with the smart apps and everything, these things are easy to do. But the National Institute of Health score talks more about the interior circulation, the carotids, but less of the posterior circulation, the vertebral-basilar. But again, majority of the strokes are interior and less are posterior. But it's more geared towards the interior circulation strokes. So I'm not going to go into the details, but you need to have them read. Again, these are now in Urdu versions as well. And then once you have a score, you can put them in any category, because all these scores will tell you the prognosis, will also tell you whether the TP or the tenecteplase will be helpful, will also tell you whether this patient might not benefit from the thrombolysis and would require a thrombectomy or endovascular or a combination. So that's why calculating the score and assigning them the category is very important. How do we figure out whether this is a large vessel occlusion? So again, the NI stroke score, anything more than 6 and above, is considered large vessel occlusion until proven otherwise. Until proven otherwise means you are going to do a CT angiography or going to do a DSA, and there are other scores as well, but the NI stroke score actually tells us whether this is a large vessel or it's not a large vessel occlusion. So once the neurologist has done everything, the CT is being done, the only thing you need is a CT plane. If you have an endovascular center, you can order a CT angiography simultaneously to reduce time, but you just need a plain CT brain, not a contrast study. And once the CT is done, you need to decide, based on the CT findings, the clinical history, the lab findings, whether the patient qualifies or not qualifies for the TPA. And within 60 minutes, the golden hour, you need to start the therapy. And the TPA runs over an hour. The tenecteplase is just a one-time bolus. That's why it's much more easier to give as compared to TPA, and that's why it's showing more and more in use in the developed countries as compared to the developing countries. So what are the guidelines? Any acute stroke patient who fulfills the criteria for IV thrombolysis must get the TPA, even if you have a thrombectomy center. So you cannot bypass giving the TPA. When we're getting the consent, we tell them the risk is up to 6.5%, but actually the major risk is not more than 2.5%. So the rest of the 4%, 6.5 minus 2.5 are the mild hemorrhagic conversions that can take place in the next 24 to 48 hours, but usually they're not symptomatic. When we're giving the consent, taking the consent, we tell the families that patients who receive the TPA, their 3 months outcome are going to be better as compared to those who are not going to get TPA. So that's something that needs to be communicated with the family. It's a weight-based, just remember the number 0.9, the maximum is 90, so 0.9 milligram per kilogram, you cannot go beyond 90 milligrams. And for tenecteplase, it's, remember 0.25 milligram per kilogram, the maximum is 25, and you cannot go beyond 25 for tenecteplase. Again, just for your audience, I just wanted to summarize, when we are giving the drug, before, during, and after, the 4 things that we're going to be monitoring very aggressively for 24 hours are the neurological examination. You have to do it every 15 minutes, 30 minutes, hourly for 24 hours. Blood pressure, if someone is going to bleed, it's probably going to be because of the uncontrolled blood pressure, and you need to keep it below 180 and 105. Blood sugars ranges 140 to 180. Hyperglycemia and hypoglycemia can also affect the outcome. And you need to monitor frequently also for the minor bleedings, which I've hardly seen these type of things. So I'm just going to quickly share some videos. I might go beyond 3 minutes. just going to quickly go forward, and I just want to share with you one last thing, and I'm done. This is a new program that has been launched by Punjab government. So that's why I thought this is going to be a good forum where you should know about this thing, because it's going to be a very revolutionary change this year. We're going to be making 18 primary stroke centers across Punjab, southern Punjab and everything, trying to reduce the burden on the urban centers. So Services Hospital has been made as a cost center, as a hub. So we've already selected 18 centers. They've already been tuned this coming week.